Well, thanks very much, Scott and Cara, for the invitation to be here today. And it's a privilege to be here to speak to all of you today. And I'm actually very humbled to be here. Just to follow up on what Tony had to say, I think I'll put what remains of my glass of wine down to to show that it is what is on the inside that does count in this context. And if a little wine will help to that, will help that cause, I have no objection to that. So it's also a challenge to follow Tony speaking, who not only chaired our medical advisory board, but who really taught me what it is to be a patient advocate in the context of a situation where I went from when I was diagnosed in 1998 with metastatic colorectal cancer, and having 5-FU is basically the only drug available, to a buffet of products which include small molecules and all sorts of biologics that exist today. So thank you, Tony, and this is kind of like following your professor when you have to speak after Tony, who speaks so eloquently. But thanks for this opportunity again. And I'm going to speak to today, and I promise I did not speak to Tony before, so if you see any concordance between our slides, it's just through years perhaps of working together that some of these things may seem in parallel. But from a patient perspective, we are also concerned about the question of value. And if we have to set a little bit of a background, therapeutic innovation continues to grow at all times today as targeted therapies enter the clinical practice, enter your practice. And we see this more and more, and really almost faster than you can get hold of it, and certainly the patients can get hold of a good understanding of what it's all about. Increased survivorship is transforming the approach by tumor type. And specifically by tumor type, we really have seen where we were blasting everything, for example, with 5-FU all around, and now with very targeted therapies for KRAS wild type, for example, with cetuximab or panitumumab. So really working from acute by tumor type, from acute treatment to chronic disease management. People are living longer. And this has resulted in a change of focus to total patient care encompassing quality of life issues. And I don't know how many times a day you hear about quality of life, but we hear about it all the time from the patient perspective. And also there is pressure from all sides for better access to affordable cancer treatments as costs have dramatically increased. So that's really just by way of background. But what are stakeholders focusing on? They're really focusing on overall treatment value. And we're going to hear a lot about that in the coming years. And there is a shift. I remember Bill is in the back, and we were talking a lot about evidence-based medicine for a while, and that's the only thing that counted. But really, today, we're moving, or we're enhancing the evidence-based medicine with value-based medicine. And value-based medicine is more than just managing drug costs. It's part of a broader debate on access to treatment that includes differing, and we heard a little bit from Tony. You're going to see another slide that I'm going to show that's not too dissimilar, but in a different, formed in a different way, that's differing stakeholder expectations on value in cancer care in general. And different stakeholders have completely different perspectives. And there is a shift from product-oriented approach rooted in science and efficacy to broader assessment that includes pharmacoeconomics, therapy management, and I'm going to underscore the therapy management part, and I think, Scott, you've been a big proponent of that. We've talked over the years on this. Compliance issues, and of course, patient quality of life. So how do we define value? That's really, how do we define it and how do we measure it? Well, Warren Buffett says price is what you pay. So we hear a lot about the cost of drugs. But value is what you get. And that's really what we're truly concerned about, as patients anyways. And at a recent meeting, the annual meeting of the Association of Community Cancer Centers in the United States, patients were asked to define what value means to them. And all patients agreed that they have to play a key role in assessing the value of treatment. And for one patient who was diagnosed with brain cancer at the age of 29, value meant getting into a clinical trial that would give him the best chance of living longer so that he could spend more time with his wife and children. Well, who wouldn't want that? And focus, another person said, focus most on quality of life that a treatment will give them. From the patient perspective, knowledge is power. So choice, commitment, care, collaboration, community, communication all need to be part of defining value. And that kind of sounds like motherhood, like a motherhood statement. But I would underscore the word choice as well here. So this is kind of like the slide that Tony showed. All stakeholders want to reduce the burden of cancer and prolong life with quality, but all have different perspectives. The patients have the most vested interest. There's no question about that. Advocacy groups such as ours, well, we want equal and timely access to effective treatments to improve patient outcomes. And I have to thank George Broman for the to improve patient outcomes, because every time I used to say just we want access to effective treatments, but of course we want to improve our outcomes as well. And physicians want all the options to have the best outcomes for their patients. So the three of us sort of on top here are really perfectly in accord. And here's where the road starts to separate a little bit. Healthcare providers, they want best treatments with their system, within their system of provision and budget. Regulators, they want fairness and diligence in assessing the risk-benefit ratio according to their methods of appraisal. And government agencies, they're concerned with policy and direction on best spending practices to ensure overall population good health. While third-party payers, insurers in other words, they want best value from available funds when covering prescription choices. So everybody has a bit of a different interest, and we're all competing for the same thing, really, but when you get after the first three groups, the money part starts to become much more important from a societal point of view and from a government point of view. So I think this slide is really important. This slide looks at the considerations that take into account clinical efficacy and also builds a perceived or actual value of a drug. What's important? Where is this value coming from? We know we have to pay. If they say $60,000, $100,000 for a course of treatment, well, what value are we getting from that? From a patient, so how do we get this value? We have to be very precise on how we do this in the future, and we're going to talk a little bit about collaboration between the patient and the oncologist. Patient selection is vital. Combining drugs based on mechanisms of action that match tumor types is fundamental. We need new biomarkers. In colon cancer, we heard of KRAS for sure, wild type for cetuximab and panitumumab. But now, what about all the other RASs? And what other biomarkers are out there? Are there biomarkers for aflibercept coming onto the market probably soon, and for Avastin and bevacizumab and so forth? We need these biomarkers to identify those patients who do best from these drugs. Drug selection, taking into account short and long-term outcomes as well as future options. Well, we've had a lot of discussions about this, and this is some things that as oncologists, you have to really think about in advance. You know, a patient walks in the door. We should be doing KRAS and RAS testing from day one. I know hardly anybody does that now. They maybe wait for second line. They should be doing it up front. They should be thinking about the treatment options. What about that surgeon who, if you give a irinotecan for too many cycles, is going to have to operate on a mushy liver, and maybe it'll explode and who knows what? How do you best serve that patient, not only through patient selection, but with drug selection? Safety and quality of life considerations, of course, cost and pharmacoeconomics of treatment choices. As oncologists, it's a little, you sort of have to follow the guidelines of your province, so that's a little bit hard to get into. Adherence is a big issue for the more and more oral medications that are entering the marketplace, and regulatory issues that affect reimbursement and patient access to new therapies. So ASCO has launched recently a strategic initiative to define value in cancer in general. And they're currently developing working definition of value they're currently developing a working definition of value specific to oncology. The Value in Cancer Task Force is working on an algorithm that will help oncologists to determine the value of different cancer treatments And within that framework, value will be defined by three components: clinical benefit, toxicity, and cost. And these are really nothing really very dramatic. Clinical benefit being the treatment that demonstrates an improvement in survival compared with no therapy when appropriate, or a known effective therapy, although this can sometimes differ, for example, in improvement in time to disease progression. And secondly, toxicity, the degree of treatment-associated adverse events, particularly those that affect quality of life or the ability to complete usual activities of daily living, many of which can be managed with appropriate or supportive additional treatments. And finally, cost, the expense incurred by patients, society, and insurers. So what about oncologists, patients, and this ASCO algorithm that will hopefully come to be soon? The algorithm hopefully will assist both the oncologist and the patient to make better and more fully informed decisions. And this is something that Tony was speaking to a little bit earlier. Oncologists now will be more than ever required to have a better understanding of the relative value of interventions and drugs that will be needed to improve the ability to discuss treatment options with their patients. So get ready to discuss with the informed patient. Not just me, but a lot of patients are online out there, and I'm sure that you know in your own practices, they're coming in with piles of paper from the research that they have done. Patients will also need to have readily accessible information about the value of different treatment regimens to help them select the treatment that meets their individual needs. And I'm a big believer in individual rights. Of course, I'm from Quebec, so why wouldn't I believe in individual rights lately? But individual needs so that they can make informed choice. And you know, there's a lot of discussion about what informed choice is. And that's not going to apply to every patient, but there are many patients who really want to be engaged and make that informed choice. So in conclusion, patients actually, in fact, do have the most vested interest of all the stakeholders, and their input must play an essential role in determining the value of cancer treatments. And we're going to hear a ton of about value in the coming weeks and so forth with ASCO coming up. Value needs to be defined, and it needs to be measured, and takes into account many considerations that ASCO has summarized as clinical benefit, toxicity, quality of life. Oh boy. Oh boy, you don't go there. Not yet. You don't want to have the punchline before. Okay, cancel? Okay. This will cancel the current backup, yes, okay.
Sure.
We don't need backup. Value needs to be defined and measured and takes into account the many considerations that we refer to as clinical benefit, toxicity, quality of life, and the cost of the drug. Patient selection and treatment planning is not just key, it's paramount. Both oncologists and patients need to be better equipped to make informed decisions. The ASCO algorithm that will be made may help, but we must evaluate that within the Canadian context, which is somewhat different than the American context. And value-based medicine must aim to help us identify the drugs that offer the most overall value to patients. And the Canadian drug reimbursement approach needs to prioritize the concept of value, even within the present P-coder slash CADETH. There's improvements that could be made even with the existing formulas that we have and procedures to take into this concept and to give greater weight to the value, once we define it properly, in the context of drug approval. Unequal and non-access to drugs that demonstrate value is completely unacceptable, and we need national guidelines, something that's really hard to establish in this country with the constitutional issues that we have. So I'll leave you with, I think Warren Buffett would be very proud because I didn't pay for this at all, so I'm getting great value, with this little cartoon that says, I'm writing you a prescription. Do you want a longer life with less quality, or vice versa? So thank you for that.